Alcohol is a small molecule, it gets into every organ of the body, including the brain, and it is a poison. So we need to think through how the harms that it ultimately causes can be addressed.
In England, alcohol is now the leading cause of premature death and ill health for people aged 15 to 49, and alcohol-related deaths are at the highest number ever recorded. Evidence shows that quality treatment services can save lives and are cost-effective. For every £1 spent on treatment, the return is £3 in savings, rising to £26 over 10 years. Despite this, most people struggling with problematic alcohol use aren't receiving treatment. Over the past decade, a lack of political interest in addressing alcohol-related harms, chronic underfunding, and fragmented services have left us without an effective approach to addressing alcohol-related harms across our healthcare services. There is a clear need for a health system's response to addressing alcohol-related harms. But why is such a response more urgent now than ever? How have reforms to healthcare services contributed to a worsening situation? What can the government and the NHS do? And why should such a response to alcohol harm be an essential part of the Labour government's mission to rebuild Britain? In 2019, before the COVID pandemic, deaths from alcohol in England were already at near record highs. In February of 2020, around 4.8 million adults in England were drinking at levels likely to cause harm to their health. Worryingly, by September of the same year, this number had nearly doubled to 8.4 million. Every year since the COVID pandemic, we have seen a record high for the number of alcohol-related deaths in England and across the UK.
Well, the evidence is really clear. During the pandemic, people who were already drinking at increased or high risk levels drank more heavily. And this sadly translated into an increase in alcohol-specific deaths by 32.8% over the first 2 years of the pandemic.
The rise in alcohol consumption since COVID has deepened inequalities across the country, with studies showing that there will be a larger impact on people from more disadvantaged backgrounds. In fact, in the years following the pandemic, we have seen twice as many deaths from alcohol in the most deprived areas of the country compared to the least deprived areas, despite people from more deprived areas drinking less on average. Alcohol-related health conditions place an immense strain on NHS resources. In 2021, nearly 6% of all hospital admissions in England were alcohol-related, around 1 million admissions. Over the past 20 years, alcohol care teams, or ACTs, have been introduced in some hospitals because clinicians were concerned about the lack of coordinated care for patients with alcohol dependence and related health issues. ACTs are multidisciplinary teams made up of specialist clinicians with expertise in alcohol-related care. In 2019, the NHS long-term plan committed to establishing ACTs in the 25% of acute hospitals with the greatest need. Evidence shows that ACTs can effectively identify at-risk patients and reduce hospital bed days. ACTs do not directly provide treatment for alcohol dependence. Instead, they support the referral of patients to community and other treatment services once they leave hospital. However, in practice, many ACTs find this challenging as they are often not effectively joined up with community treatment services or with other mental and physical health services within the NHS. Unfortunately, the programme was deprioritised by NHS England in March of 2024, with many ACTs now being dismantled despite having barely become established.
I think it's been a disaster. I think joining up services is the biggest single challenge in a way. I think we've got hospitals reasonably well sorted. We can't be complacent, but alcohol care teams have really developed well in the last decade. But there's often that huge gap when they leave hospital and fall between the cracks as they go into community services.
The lack of coordination between the NHS and community treatment services often means that even when healthcare professionals detect problematic alcohol consumption or dependence, many people do not enter treatment for their drinking after leaving hospital. This often results in hospital readmissions, causing additional costs for the NHS that could have been prevented with earlier access to treatment. In 2015, just 9% of people with alcohol dependence accounted for 59% of all alcohol-related hospital admissions, over 365,000 admissions in England, costing the NHS approximately £858 million. Assertive outreach targets these high-need individuals by providing tailored, proactive support to reduce hospital visits and improve their overall quality of life. The results are often remarkable. A study found that patients supported by an alcohol assertive outreach team saw their days of not drinking increase from 14% to 68%, while their days in hospital as an inpatient dropped from 26.8 days to just 1.2 days. Scaling this model across England to help over 50,000 high-cost patients is estimated to cost £161 million, but it could save the NHS around £575 million, equivalent to a return of £3.42 for every pound invested. However, despite its proven success, the availability of assertive outreach services across England is inconsistent. Some areas lack these services entirely, whilst others have experienced funding cuts since 2013.
I think A&E staff now see there is something that can be done with the patients and bring in the alcohol care teams, but the problem comes when the patient goes home. We see this particularly in patients with alcohol-related brain injury, where for years we've dismissed them as being feckless and just not turning up for follow-up. But of course, about a third of the patients with alcohol dependence have serious cognitive impairment and are just unaware that an appointment has been made for them. So we've developed a study on using an assertive outreach team to help support those patients in the community and to help support the families, equally importantly. But that is running at the moment on charitable funding, not NHS funding.
Between 2013 and 2021, the number of people in alcohol treatment dropped by 16%, even though the number of people in need of treatment remains steady. For those who do access treatment, the outcomes can be positive. 59% of people complete their treatment program successfully. Yet, the vast majority of individuals with alcohol dependence are not getting the support they need to recover, leaving them at risk of severe health complications or hospitalisation. This lack of access is costly, not just for individuals and their families, but also for the NHS. So why has the situation become so much worse? Well, several inquiries over the past decade investigating this lack of access have pointed to the reforms introduced by the 2012 Health and Social Care Act, as well as subsequent cuts to funding for alcohol treatment services.
So the Health and Social Care Act of 2012 effectively moved commissioning of treatment services out of the NHS into local authorities. And this then had two related but supra-additive effects on the treatment system. The first was that local authorities had really tough decisions to make about what they were going to fund and not fund, as their own budgets were slashed through 10 years of austerity. Second, it enabled NHS services, particularly mental health trusts, who used to previously host specialist addiction services, to essentially decide that they no longer needed to treat people with alcohol dependence, as it was no longer part of their remit.
After these reforms, local authorities had to rely on the public health grant to fund alcohol treatment services. However, following years of austerity, the grant has been reduced by 28% in real terms, reflecting £630 million in budget cuts. Today, the grant accounts for just 2.2% of the overall NHS England budget, forcing local authorities to stretch these limited funds across a wide range of public health services, including addiction treatment. These cuts have had devastating consequences for drug and alcohol treatment services, with spending on these services falling by 21% in real terms over the same period. Despite recent funding increases under the government's 10-year drug strategy, spending has still not returned to 2015 levels.
Once commissioning of services went into local authorities, they had difficult decisions to make about what to fund. And consequently, when they re-tendered for specialist addiction services, they tended to take the cheapest bidder. This has been described as a race to the bottom. And consequently, it meant that there was a reduction in both quality and quantity of treatment that was provided. There was a loss of clinical and social work expertise, and also a reduction in how best to use people with lived experience. So instead of them being a really vital part of the treatment service, they essentially became cheap labour, replacing more specialist clinicians.
Successive budget cuts and frequent changes to service contracts have left many treatment providers struggling to recruit and retain staff with formal qualifications or clinical training in addiction treatment. The amount of funding provided by local authorities for treatment services also varies widely across the country. This has created a postcode lottery where the quantity and the quality of alcohol treatment services depend heavily on where you live. But reducing spending on alcohol treatment services doesn't actually save money. It simply shifts the costs onto the NHS. Research has found that every 5% cut in alcohol treatment funding results in an additional 60 alcohol-related hospitalisations per 100,000 people in the population. Successive budget cuts were not the only unintended consequence of the 2012 reforms. Moving the commissioning of addiction treatment services out of the NHS often meant that alcohol treatment services operated in isolation from other parts of the healthcare system, leaving patients with co-occurring mental and physical health conditions without the comprehensive care they require. While the intention may have been to streamline services, the result has been a fragmented system in which the broad range of physical and mental health needs of patients with alcohol dependence is no longer seen as a priority within many healthcare services. Alcohol dependence and mental health issues often go hand in hand. A staggering 71% of adults and 48% of young people who enter alcohol treatment services also require mental health support. Unfortunately, the current system is ill-equipped to meet these dual needs. Years of budget cuts have drastically reduced the number of qualified health professionals in the addiction treatment sector. The shortage of addiction psychiatrists is particularly alarming. Between 2011 and 2019, the number of training posts fell by 58%. As a result, many community addiction services do not have the expertise to provide adequate care for individuals with severe alcohol dependence and complex mental health needs. At the same time, many mental health services are often reluctant to treat patients until their alcohol use is under control, creating a vicious cycle where patients with both conditions are left without the care they desperately need. The consequences of this lack of integrated care can be tragic. Between 2010 and 2020, nearly half of people who died by suicide while under the care of mental health services had a history of problematic alcohol use. Despite this strong link, the healthcare system often fails to provide proper support for people struggling with both alcohol dependence and mental health issues. Managing alcohol dependence within the healthcare system requires a workforce equipped with the right skills and knowledge. However, as the responsibility for commissioning treatment services no longer sits within the NHS, many healthcare professionals lack the necessary training to effectively identify and manage patients with problematic alcohol use and dependence.
Patients with advanced alcohol use disorder are out there. They're coming into our A&Es. We need to treat them, and the current facilities are woefully inadequate. In hospital, they're not too bad, and alcohol care teams have been a game changer, but as soon as they go into the community, they get lost. So that is a priority, to get proper funding for them. But we mustn't lose sight of the earlier stages, trying to get early detection of people with problems, having a pathway for them. And then ultimately, of course, the key to success is preventing the next generation coming along. So prevention of alcohol-related issues is key.
Many opportunities to detect and address higher-risk drinking early when people get in contact with health services are missed, with just 23% of referrals to community addiction services coming from healthcare providers. GPs and non-specialist healthcare professionals working in hospitals and mental health services frequently encounter patients with alcohol-related harms and are often the first point of contact for people with problematic alcohol use. However, many lack the time and the training to screen for alcohol consumption and alcohol use disorders, or to provide brief interventions, or to make referrals to specialist services. The rise in deaths from chronic liver disease underscores the importance of healthcare professionals across the NHS having the skills, time, and knowledge to identify and manage problematic alcohol use and alcohol dependence. Deaths from chronic liver disease have quadrupled since 1970, and in 2022, 76% of all alcohol-specific deaths were caused by alcohol-related liver disease. Early detection of liver disease could significantly improve outcomes, as studies show high recovery rates when the disease is diagnosed early. Yet, 3 out of 4 patients with cirrhosis are only diagnosed at an advanced stage, when treatment options are limited. Tragically, a quarter of these patients die within 60 days of being admitted to hospital.
I think we're very poor at thinking about alcohol-related liver disease in its early stages. I think we could do a lot better at picking it up early when it's potentially treatable, both in the physical sense and in any dependent sense. So we definitely need an increase in services for early detection of liver disease. And we've got a new tool. The FibroScan is really a game changer. It's not that complicated, it's not that expensive, but it's been quite slow to get introduced. The British Liver Trust have done a lot of good work going into supermarkets, car parks with a FibroScanner, encouraging people to come on in. And I think we need some more formal approach to that so that there could be clear pathways when people have slightly disturbed liver blood tests, they feel well in themselves. Can you filter them into a proper pathway to determine the cause, and if it's alcohol, to treat them early?
The lack of universal screening and early intervention leads to preventable deaths and increases healthcare costs due to the need for more complex and urgent care. So what can be done to improve the way our health services respond to alcohol-related harms?
So the Medical Council on Alcohol has been working on this project with a number of other partners, including the IAS, calling for a national strategy to address alcohol-related harms through interventions, principally through the health service. We recognise that there's a need for primary prevention through interventions such as minimum unit pricing, but there's also a real need for health service level interventions. So with the massive increase in alcohol-related harms and deaths, which has increased even since COVID, and the huge weight on the health service, we're looking for a national strategy which will then address the provision of alcohol treatment services throughout the health services, both specialist services, primary care at all levels. What we find at the moment is the level of provision is vastly outweighed by the need that's out there, and we would like to address this problem through this strategy.
This strategy should aim to improve the treatment and secondary prevention of alcohol-related health issues and problematic drinking, in addition to primary preventative measures like addressing the affordability, availability, and marketing of alcohol. An updated national alcohol strategy must focus on reducing health inequalities, providing equitable access to treatment, and improving integrated care pathways to truly build an NHS fit for the future.
I think we need to start with a national strategy, which would then enable us to focus on how we built pathways for people wherever they are and wherever they present. And this would have a number of strands to it. I think the first would be sustained funding to enable treatment services to develop and grow, rather than to be always looking over their shoulders to see where the next pot of money was coming from, and to also encourage staff to stay and build their careers within it. The second would be universal screening. So wherever people presented, be that in mental health services, primary care, acute trusts, for whatever form of alcohol-related harm, they could be identified, and we would genuinely have a no wrong door policy.
To drive meaningful change, the Medical Council on Alcohol calls for every regional and national health board to appoint an alcohol lead. These leaders would ensure coordinated care for individuals with alcohol dependence, addressing both physical and mental health needs. Regional health systems should rebuild high-quality alcohol treatment services in line with new clinical guidelines, ensuring they meet local needs. Local systems should also implement accelerated pathways for conditions like decompensated liver cirrhosis, ensuring timely access to life-saving care. Given the strong link between alcohol dependence and suicide, integrated care boards should incorporate the management of alcohol dependence into their suicide prevention strategies. Acute hospitals, often the first point of contact for patients, should universally screen for problematic alcohol consumption and alcohol dependence to enable earlier intervention. People in alcohol withdrawal often receive unscheduled inpatient treatment in acute hospitals. To alleviate pressure on acute hospital services, local authorities should commission specialist inpatient alcohol treatment beds. Consultant-led alcohol care teams must be established in all hospitals to improve the quality of care and ensure seamless referral pathways to community services. Strengthening links between hospital and community care is crucial to creating effective pathways for recovery. Mental health services also play a critical role. Each locality must have a crisis care pathway to ensure suicidal patients with alcohol dependence have access to timely care. All staff working in these services should be trained to assess and manage alcohol use and dependence as part of their suicide prevention plans. Clear policies are also needed to address co-occurring alcohol dependence and withdrawal in people requiring inpatient treatment.
We need to involve people with lived experience in the design and delivery of treatment services. And finally, we need to improve the health literacy, the alcohol-specific health literacy of health and social care professionals.
Rebuilding alcohol treatment services is essential for the Labour government's goal to prioritise prevention, ease pressure on the NHS and strengthen healthcare. Despite the 2012 reforms moving addiction services out of the NHS, alcohol-related harms cost the NHS around £4.9 billion every year. By improving treatment access, we can intervene early, preventing conditions from worsening and reducing long-term healthcare costs. This approach keeps people healthier and helps the NHS allocate resources more effectively. Alcohol harm also impacts social opportunities. Around 3 million children in England live with a parent who has an alcohol problem, putting their emotional and social development at risk. Better treatment access can support these families and reduce the negative effects on children's futures. Over the past decade, a lack of political will to address alcohol-related harms has had disastrous consequences for individuals, their families, and the NHS. Every year since 2019 has set a record high for the number of alcohol-related deaths. Now is the time to act decisively to reverse this trend and ensure that everyone in need of treatment can access the support they deserve.
For more information on this topic, check out the briefings on our website.